Now that we have finished our discussion of neurotransmitters, let's move on to each of the major drug classes. The first class we will cover are the antidepressants, both because they are among the most widely prescribed class of drugs in all of medicine, and because their neurotransmitter profiles are fairly well worked out at this point. Just as a quick reminder, you can use the mnemonic SIG-E caps to remember the symptoms of depression. Having at least 5 of these qualifies the patient for major depressive disorder per DSM standards. One thing that students often get tripped up on tests is exactly how long the SIG-E cap symptoms have to occur before they are considered a true major depressive episode. I use the mnemonic 2 blue weeks to remember it. The first class of antidepressants we'll cover are known as serotonin-specific reuptake inhibitors, or SSRIs. These work by inhibiting the transporter on the presynaptic neurons that take serotonin back up into the cell, effectively increasing the amount of serotonin active and available in the synaptic cleft. Let's quickly review serotonin's functions using our HEAD, RED, and FED mnemonic. HEAD refers to the psychological effects, including feelings of satisfaction and decreased impulsivity. However, this is coupled with a decreased sex drive, which can be problematic and, indeed, is actually the number one reason why people stop taking SSRIs. RED refers to serotonin's effects on platelets. Remember that SSRIs can occasionally cause prolonged bleeding. Finally, FED refers to the GI effects, which are prominent side effects of SSRIs and represent another common reason why people stop taking them. One thing to counsel patients on is how long SSRIs can take to work. In multiple studies, it has been shown that maximum treatment efficacy is often not reached until 4 to 6 weeks. Patients can sometimes feel like discontinuing the drug on their own, as the side effects, like diarrhea or restlessness, are immediate, while the desired effects can take weeks. Fluoxetine, or Prozac, was the first and most immediately successful of the SSRIs to be released in the late 1980s. Prozac is the brand name for fluoxetine, and we can use that information to help us remember some clinically important information about it. Fluoxetine has one of the longest half-lives of any SSRI. Why is this important? Because fluoxetine, as well as its metabolite norfluoxetine, stay in the bloodstream longer. It works better for people who aren't great at remembering to take medications regularly. However, on the other hand, because it lingers in the system so long, you have to be careful not to switch to another serotonergic drug too fast, as the levels can get high and cause serotonin syndrome. By focusing on the flu part of fluoxetine, it will help us to remember that fluoxetine, like the flu, generally lasts about 1 week. So when you see fluoxetine, think of the flu and the week that you had to spend in bed that 1 year that you got it. The next drug, a popular choice, is sertraline, or Zoloft. The mechanism of this drug is easy to remember, as the ser of serotonin is built right into the name sertraline. I had a hard time remembering to pair sertraline with Zoloft until I started pronouncing it zertraline in my mind. Zertraline, Zoloft. Sertraline has harsher GI side effects such as nausea and diarrhea than other SSRIs, which has earned it the endearing nickname of squirtraline. Tell your patients to take it with a meal to help absorption and to decrease these side effects. In addition, sertraline is also one of the safer SSRIs for pregnant or breastfeeding women, as less of the drug gets into the breast milk. So, if you use your imagination a little bit, the mnemonic squirtraline should work here too. Paroxetine, or Paxil, is another SSRI, and this one is unique in that it is very rapidly absorbed. This can result in worse side effects when a patient first begins the drug, as a higher amount of the drug gets into the bloodstream in a shorter amount of time. It's something to counsel patients about when you start them on paroxetine, to expect some initial side effects before the actual clinical improvement is noticeable. Also, if they are to suddenly stop taking the drug, the withdrawal will happen much faster and result in a bad and uncomfortable withdrawal state. How to remember this important fact? I like to focus on the per-ox part of paroxetine. If you played Oregon Trail, you'll remember that you moved much faster with a pair of ox than with a single ox. One side effect of paroxetine's rapid absorption is that it can produce withdrawal symptoms, not only in patients, but also in babies born to patients taking paroxetine, when they are suddenly withdrawn from the drug when they are born. This can, at times, even result in seizures, so be careful about putting someone on paroxetine if they are pregnant. The next 2 SSRIs are basically siblings. First, we have citalopram, or brand name Celexa. This drug is generally considered to be a middle-of-the-road SSRI, and is considered by some psychiatrists to be an excellent first-line agent due to its overall high tolerability. Its main benefit is that it is fairly clean in terms of enzyme interactions. However, there is some concern about its effect on the QTC interval, so at higher doses, over 40 mg per day for adults and over 20 for the elderly, it's a good idea to get yearly EKGs on these patients. How to remember this? I like to rename this as Selexis to remind me of the car. Why a car? Well, a car should hopefully remind us to get an electrocardiogram on these patients. I even threw in a picture of a Lexus electric car. S-citalopram, or Lexapro, is basically the awesome younger sibling of Celexa. It's the S enantiomer of Celexa, which is the pharmacologically active form. So a 10 mg dose of S-citalopram is about equivalent to a 20 mg dose of citalopram. Even more so than citalopram, S-citalopram is the cleanest SSRI in terms of enzyme interactions. The next SSRI is fluvoxamine, otherwise known as Luvox. Fluvoxamine is actually a fairly old antidepressant, but in the US it has only been approved for obsessive-compulsive disorder. I try to remember the association of fluvoxamine with OCD by pronouncing it Luvox with an OC, or in the generic form fluvoxamine, with OC standing for obsessive-compulsive. A quick note. Fluvoxamine is not the only SSRI that is helpful for OCD. In fact, nearly any of the SSRIs seems to have beneficial effects in treating obsessive-compulsive disorder. Fluvoxamine is just unique in that it is FDA approved for OCD, rather than major depression, although in all honesty this is not a high-yield fact. While serotonin is definitely implicated in the treatment of depression, it is not the only neurotransmitter at our disposal. Each of the monoamines plays a unique role in depression. As you recall from our earlier slides, serotonin is involved in feelings of satisfaction and anxiety. Norepinephrine, on the other hand, brings increased energy and focus, both of which are lost in depression as well. Each neurotransmitter seems to regulate different parts of the effects of depression. How does this work out in clinical practice? Let's see. One drug that boosts both serotonin and norepinephrine is venlafaxine, brand name Effexor. This is a reuptake inhibitor for both serotonin and norepinephrine. How can we remember this unique mechanism? I like to focus on the N sound of venlafaxine to remind me of norepinephrine. So how does the norepinephrine impact treatment? Depending on how the patient presents, you might want to consider venlafaxine over a simple SSRI. If your patient's primary symptoms are lack of energy, decreased interest, and impaired concentration, venlafaxine may be a preferred choice. However, with the addition of a new neurotransmitter comes new side effects. One prominent effect of venlafaxine that is not seen in pure SSRIs is hypertension. Patients started on venlafaxine have about a 50 to 100% higher risk of developing hypertension, which is likely due to norepinephrine's effects on the peripheral vascular system. However, the vascular effects tend to be short-lived, so it's not a reason not to put someone on it unless if they have a history of hypertension. Another drug in this class of serotonin and norepinephrine reuptake inhibitors is duloxetine, brand name Cymbalta. How to remember this dual mechanism? Focus on the dual part of the duloxetine name. That should help remind you of the dual mechanisms at play with duloxetine. In addition to depression treatment, duloxetine is often used to help people with chronic pain conditions, as it seems to mitigate pain sensation to some degree. You can remember this by thinking duloxetine in addition to duloxetine. Dull for dulls the pain. Duloxetine. Another drug that works on both serotonin and norepinephrine is mirtazapine, brand name Remeron. The mechanism here is a little bit different, and we won't get into it too much. But basically, mirtazapine inhibits an inhibitory input to the sympathetic nervous system, effectively enhancing sympathetic output and counteracting some symptoms of depression. From a clinical standpoint, you'll run into mirtazapine in nursing homes and cancer clinics. Why? Because it seems to have strong effects at increasing appetite, which can help guard against the cachexia seen in patients with cancer, HIV, or simply advanced age. I remember this with the mnemonic mealtazapine, because mealtazapine makes you want to eat a meal. Also helpful for these patients, mirtazapine tends to decrease nausea in contrast to the standard SSRIs. If adding norepinephrine into the mix works, then why not try increasing dopamine as well? If you'll recall from our dopamine mnemonic, drive and attention are crucial functions of dopamine that are lost in depression. Out of this thought came a drug called bupropion, brand name Wellbutrin. Unlike the antidepressants we've studied so far, bupropion doesn't have significant serotonergic effects. Instead, it works its magic primarily through dopamine and norepinephrine. You can remember this mechanism by focusing on the bu part of bupropion and associate it with the word butane. The word butane should help you link bu to DA and NE, which stands for dopamine and norepinephrine. Butane can also help us remember some of the features of bupropion. The fire from a butane lighter is used to light birthday candles, which makes people feel warm and happy. You can also think of fire as being hot and steamy to remind yourself that bupropion does not have significant sexual side effects. And finally, you can think of using a butane lighter to light a cigarette, as bupropion is indicated to help patients stop smoking. All of this information all packed into a single syllable, bu, that will help you think of a butane and fire. So what's the downside to all this happy-feeling, sex-crazed, cigarette-quitting excitement? Bupropion, by virtue of its excitatory properties, has a propensity to lower the seizure threshold. This is particularly noteworthy when working with patients with bulimia who engage in frequent vomiting, as this can cause electrolyte imbalances that help further raise the risk of seizure. For that reason, treating a bulimic patient for depression using bupropion is strongly contraindicated. The next drug we will discuss, trazodone, brand name Deseril, is unique in several regards. First, in addition to an antidepressant, it is commonly used as a sleeping aid. Interestingly, its effects on sleep work best in patients with depression, so it's not exactly an all-purpose sleeping pill, even though it's sometimes treated as such. Secondly, its mechanism of action is a bit weird. It's both a serotonin antagonist as well as a reuptake inhibitor. The mechanism isn't important, so don't lose too much sleep about it. One unique feature about trazodone is one of its side effects, priapism, or an erection lasting several hours. This is a medical emergency, as blood flow to the engorged organ gets compromised after a while, so it's worth counseling your patients about what to do should they experience the side effect. I stole this mnemonic from first aid, but you can remember this by thinking trazobone. Trazodone, trazobone. Now we come to the oldest class of antidepressants, and some of the first drugs to be officially prescribed for that purpose, the tricyclic antidepressants, often abbreviated TCA. As you can see, tricyclics have incredibly complex binding profiles, inhibiting the reuptake of serotonin and norepinephrine while antagonizing acetylcholine and histamine, and at the same time inhibiting sodium and calcium ion channels. Whenever I think about the complexity of TCAs, I am reminded of the third rule of neurotransmission: with great power comes great responsibility. The more things you mess with in the brain, the higher chances of having an effect, but also the higher chance of causing serious side effects. Despite their age, TCAs remain some of the most effective antidepressants, but they come with a side effect profile to match. By going through each of the neurotransmitters one by one, we can look at the pros and cons of using TCAs. As you can guess, serotonin and norepinephrine are primarily responsible for the antidepressant actions of TCAs. The TCAs are a very powerful group of antidepressants and are often reserved for treatment-resistant depression, which has failed multiple trials of less invasive antidepressant classes, such as SSRIs. Acetylcholine and histamine, on the other hand, account for more of the TCA's side effects. By inhibiting acetylcholine, you get several prominent antimuscarinic side effects, including dry mouth, itchy eyes, blurry vision, constipation, urinary retention, memory impairment, and increased body temperature. Antagonism of histamine does result in some drowsiness, sedation, and sleepiness while using TCAs. Finally, TCAs are now known to work as sodium and calcium channel inhibitors as well. This is clinically important in that you could observe some mood stabilization effects. However, much more likely to be tested on boards is the fact that taking TCAs in overdose can cause significant heart and nerve conduction abnormalities due to its effect on ion channels. TCAs are notoriously toxic in overdose, with a therapeutic index of about 7, meaning that taking just 7 times the normal amount of the drug could cause death. On boards, and you should pay close attention to this, a widened QRS complex in the context of a suspected overdose is pathognomonic for TCA overdose. This is very high yield, enough that I'm going to repeat it one more time. A widened QRS complex in the context of a suspected overdose is pathognomonic for TCA overdose. Also high yield is the treatment for TCA overdose, sodium bicarbonate. How I remember this is to think about a car running over a tricycle. It's no contest, the car is going to win every time. So from this, you can picture a bicarbonate running over a tricyclic and beating it handily. A bicarbonate wins over a tricycle every time. Putting all of this complexity together is a daunting task, but let's see if we can simplify it. TCAs act as an agonist at 2 neurotransmitters, an antagonist at another 2, and an inhibitor of 2 different ion channels. What helps me to remember this is the rhyme trans, chans, and ans, which conveniently spells out TCA. The S at the end of each word indicates the plural, or the fact that there's 2 transmitters being boosted, 2 channels affected, and 2 antagonized neurotransmitters. Trans, chans, and ans. Quick review question. In order to avoid serotonin syndrome, you need to have a washout period of usually around 2 weeks before switching from an SSRI to a tricyclic. One SSRI has an even longer washout period at 5 weeks. Which SSRI is this? If you thought fluoxetine, then you would be right. Fluoxetine, with its long half-life, requires a longer period of time before starting TCAs to avoid serotonin syndrome. This can show up on test too, so make sure to memorize this. Now we move on to the first of the tricyclics to be discovered, which also happens to be the first antidepressant ever developed. Imipramine is a prototypical tricyclic, so everything we've talked about thus far applies. One thing that sets imipramine apart is that it is sometimes used for management of nocturnal enuresis, or bedwetting, in children. Can you guess which neurotransmitter is responsible for its efficacy at helping children hold their bladders? If you guessed acetylcholine, you'd be right. The anticholinergic effect of imipramine prevents the bladder from contracting, thus holding the urine. I remember this by pronouncing imipramine as I'm peeing ramine. This should help remind you of bedwetting and the fact that I'm peeing ramine is used for this purpose. Because of its side effects, it is not to be used as a first-line agent, but can be useful in refractory cases. Another TCA with a specific indication is clomipramine. Like fluvoxamine, clomipramine is only FDA approved for the treatment of OCD. In fact, clomipramine has been shown in a couple of randomized controlled trials to be the gold standard for medication treatment of OCD, and it was found to be the most effective option over fluvoxamine and fluoxetine. However, again, due to the high side effect profile of TCAs, a standard SSRI is probably a good first line, with clomipramine being reserved for more severe refractory cases. Two other commonly prescribed TCAs are amitriptyline and nortriptyline. These are again prototypical TCAs, but in addition to depression, you will also see them being prescribed for people dealing with chronic pain issues, such as diabetic peripheral neuropathy, chronic low back pain, or pelvic pain. There are some subtle differences between amitriptyline and nortriptyline, but they are beyond the scope of this lecture. We now move on to the third class of antidepressants, the monoamine oxidase inhibitors, or MAOIs. Perhaps to an even greater extent than the tricyclics, MAOIs embody the third rule of neurotransition. With great power comes great responsibility. Because they modulate not one, not two, but three separate monoamines, MAOIs are among the most effective of all antidepressants, especially in the subtype of depression known as atypical depression. However, they also have some very severe side effects because of this. Because of these side effects, MAOIs are seen as a last resort of sorts, although with the increased use of ECT in recent years, MAOIs have not been used very often. Because of their rarity, we will spend only a few minutes considering them. One frequently tested fact about MAOIs is that they are associated with what is known as a hypertensive crisis. Basically, when a patient is on an MAOI and eats food containing tyramine, such as aged wine and cheeses, the catecholamines can build up to an extent where all the blood vessels constrict, leading to incredibly high and dangerous blood pressures. How to remember this clinically significant interaction? I like to think about being on Maui, the Hawaiian island, on a date with Miss Tyra Banks, enjoying some fine wines and equally fine cheeses. Have you formed that mental image yet? Being on Maui should remind us of MAOIs, the drug class. Tyra Banks should remind us of tyramine, the specific molecule that causes the hypertensive crisis. And the fine aged wines and cheeses we are enjoying should bring to mind the foods that classically cause this interaction. There are only two MAOIs that you'll need to remember, selegiline and phenelzine. Both are irreversible inhibitors of monoamine oxidase, meaning that the effect lasts until new enzymes can be synthesized. What is different between the two is that selegiline is selective for the B subtype of MAOI, whereas phenelzine is non-selective and hits both MAOA and MAOB. It's a little confusing, but you can remember this using the mnemonics selectiline to remember that selegiline is more selective. So what's the difference between MAOA and MAOB? MAOA degrades all three monoamines, serotonin, norepinephrine, and dopamine, as well as tyramine, as we just discussed, whereas MAOB degrades only dopamine. Therefore, phenelzine, which hits both MAOA and MAOB, is preferable for the treatment of depression, whereas selegiline, which hits only MAOB, would be preferable for something like Parkinson's, which only involves dopamine. As a final slide, here's a quick high-yield review of the major concepts and mnemonics we have covered in this lecture. Make sure you know and understand the meaning behind each of these, or if not, you can rewind and review any relevant parts. One last note. After going through this presentation, hopefully you feel like you have a better grasp on the psychopharmacology of depressive disorders. However, it's crucial to recognize when you can apply these principles on your own, versus when a patient requires a higher level of care. You can remember the criteria for referring out to a psychiatrist using the mnemonic PsychMD. P is for psychosis, S is for suicidality, Y is for why isn't this working and refers to when a patient has failed multiple attempts at treatment. C is for comorbid psychiatric disorders, including substance abuse. H refers to the highs and lows of bipolar disorder. And MD is for monitoring drugs, such as when a patient is on a drug, like lithium, that requires closer follow-up. If the patient meets any of these criteria, consider referring out to a psych MD. Okay, that's it for the antidepressants. Let's take a break.